quite a packed agenda for you today. Oh, well done, Kevin. Thank you very much, because I always forget. This meeting is now being recorded. Thank you. Welcome everybody. My name's Claire Holmes. I'm the Operations Manager for Cancer, for those that don't know me. And we've got various members of the Cancer Senior team on the call as well today, who will hopefully help me out and chip in where needed. We've got a full action-packed agenda to go through, so I will try not to linger over the slightly boring bits and let everybody else do the exciting updates. I'm gonna very, very quickly whip through some of our governance updates. We've got Kerry and various people from the CCRH team to update us on the exciting cancer hospital. We've got Gina, I'm hopeful, is here to talk about our Cancer Patient Partnership Group. Paya's here to talk about the Teenage and Young Adults Operational Delivery Network. You're testing my abbreviation understanding this morning. I think Michaela's here to talk about transgender care. Then we've got some Directorate updates and bits and pieces to update you all on at the end. So I will whip through the governance stuff to start with. What I'm going to say on this is our usual quarterly update. Hopefully within all of your specialties you will have seen some of this data already. I'm going to go through it relatively quickly, and I won't go through every slide, just in due to the time we've got available today, but I'll try and focus on some specific things. So this first slide shows us how many incidents we have submitted in the month. I think I said last time, and I'll repeat it again, submitting an incident is a good thing. It means that we are being really open and transparent when things maybe haven't gone quite to plan, or we've had a near miss. It's really important to report these things so we can undertake a review and learn any lessons from them. And you can see there that oncology and haematology are the specialties that submit most of them and are really good at reporting. We have got in the graph in the bottom right hand shows how many incidents we've got and what length of time they're at to close them down, which is an area where we really struggle. We've got to make sure that we're doing quick investigations and learning those lessons so that we don't have repeat incidents for the same thing. So that's an area that we really want to focus on over the coming months. If you want to skip on, Kevin, please. I think I'll skip over the next one. If I go to risk, sorry, the next one, yeah. So again, this shows our risk. So these are things where you think there is a risk that something is going to happen. So it's a future, get your crystal ball out kind of, and we record these where we know we've got a gap in a provision somewhere. In theory, then you could have an incident that's happened which is the same as a risk. So you could say there is a risk of me falling over down the stairs because I'm looking at my phone and not watching where I'm going, and then I could have the incident where I have fallen down the stairs because I'm not watching where I'm going. So that's how risks and incidents work together. We've got, again, by specialty, there are a large number of risks for haematology and oncology, and we've got some there that are overdue for review. So it's really important that teams keep up to date with their risks. Our risks should not sit on our risk register forever and a day. We should be doing actions to mitigate those risks and try and reduce them and close them down. And I think we do a review with specialties every quarter, and that's, again, another thing we're trying to work on to reduce them down. If you want to go to the next one, Kevin, please. This will be really important to all of you. This is around our health and safety. So this is keeping you all safe at work, and obviously our patients safe as well where they come into clinical areas. We do health and safety sort of, I don't like the word inspections, that sounds scary. We do health and safety visits out to areas and really help you make sure that you are compliant with the national guidance. And as managers of areas, it's your responsibility to make sure that we are compliant and providing a safe area for our staff and our patients. So you can see there's our programme of coming round. Really see this as an opportunity for some help and some guidance, especially if you're stuck on certain things. This should not be seen as a horrible inspection where we come and tell you all off at all. It should be, as I say, seen as a positive thing, and I think normally we have some really good areas of good practice come out of these as well, which is lovely to see. If you want to skip on one, Kevin. So there are risks associated with our health and safety. Policies is the next one. So this is it's painful, is policies. So these are our documents for oncology and haematology. We largely use a system called CUH. Some of you may have the pleasure of using CUH. And then for certain documents, we publish them on Merlin, which is the trust document a system that we use. You can see there that our Cambridge Cellular Therapy Laboratory, CCTL, have got a large amount of documents outstanding, and they're a team that has had real workforce constraints over the last year. So we're doing some extra focus with them over the coming months. But actually, we've made huge strides. We used to have policies that were overdue for review dating back 3 or 4 years, and actually we've managed to get on top of a lot of those in the last few months, which is fantastic. If you really think about it, that actually if we have got a policy that's overdue for review, potentially somebody could be operating there against out-of-date guidance. So we could be giving a treatment, doing something to a patient that's actually old and isn't our process anymore. So it's really important that we keep these up to date. I think one thing we've been a little bit guilty of in the past is we create a policy for everything under the sun. So we've got lots of policies that are then duplicate that we don't really need anymore. So again, it's really important to go through and really think, do I need a new policy, or can I add it into an existing policy? So we try and keep these as specific as possible. I'm sure you all have had the pleasure of searching on Merlin and trying to find a document, and then you can't find it because it's called something slightly different under a different name. Again, that doesn't help them when we've got various different versions and things called something slightly different. So we will be focusing on this. We tried to do a little bit in this year, and this will be one of our objectives, I'm sure, going into 2024-25. Next one, yeah, I think one after that, Kevin, the patient feedback, please. So we always try and include something in this just to remind us all about why we're here and why we do this. We get some fantastic feedback from patients, both positive and negative. We should be learning from the concerns and the complaints that people make. But I think on screen you can all have a read, and hopefully it reminds you all of why we're here, why we do this. Certainly for me, these are the things that are fantastic to read and that keep me motivated. So thank you all very much, and well done if one of your areas is mentioned on there. We try and rotate round our patient feedback so that every area gets a mention, but so it's a good thing that we get far too much to include everything on a slide. So thank you very much. And I think the next slide just shows the number of complaints, compliments, concerns. There are now multiple different categories that we get from places. What we really need to try and do is think about all those where we've got the green on there, the inquiries. Why are patients having to ring in and ask questions? Can we look at that information and make sure our website's updated, or can we let the cancer support team know so that if patients are coming down to our information pod, we're telling people there, so it saves our admin teams answering phones and repeating the information multiple times. So that's again a bit of good learning to do. I think that's me then. I've whistled through governance, and hopefully that's helpful. But on to far more exciting. I shouldn't say that about governance, should I? On to far more exciting things than governance. Carrie, Cancer Hospital.
Thank you very much. Hopefully it will be a little bit more exciting, but no doubt will be plenty of governance involved in this as well in due course. So just a short update from me. I think there might be a slide. Oh yes, there is. Thank you very much. So continues to be lots of really positive progress on the Cancer Hospital project, and you will know from our previous update that we have a commitment from the government to provide the Treasury element of the funding for this project now. So this next phase has started with us working with a construction partner who unfortunately I can't tell you who it is because they haven't actually signed the contract yet. So but we are in practice working with them anyway, even though they haven't signed the contract. But that will all happen very soon. But we are starting now to hand over our designs for this build to this construction partner so they can evaluate our designs and give us some advice on how practically they will build it and what they think of our design. So there will be a feedback loop there as that gets underway. So quite exciting. Alongside that, we are hopefully finishing off all the loose ends which have been outstanding on the design. So working with our architects to close out all those little factors on the design. Now, that also means we are challenging the project around its cost at the moment in a process of what they call value engineering, which is essentially looking for where we might be able to reduce the cost of this build. clearly we've got a fixed amount of capital funding to deliver this project, and we must keep it within that capital budget. So over the next months, you in your various teams may be on the receiving end of questions from us around really what is an essential requirement of this build versus what might be a more desirable requirement. And they're the kind of conversations none of us really want to have, because I think we were pretty stringent the first time round with what we put in this, and we've had to already think very carefully about what's in this building. But there will be questions that we need to go back round to really check that we are only putting in what we really need, and if there's any possibility for us to try and reduce the cost, because clearly if it's not in budget, then we don't build anything. And also along that route, because we are now closing down that design discussion, and to be fair, you might have heard me say that we're closing down the design discussions for about the last year, but we are right up against it now in terms of those designs. So anything else that we change in the design of this building now has to go through quite a rigorous internal process in terms of us understanding the impact and the cost of that change. So anyone that comes up with anything now that they think they need differently in their building design, I'm afraid you're going to get some questions back from me and the team around the detailed rationale for doing that, because we will have to really push that through quite a detailed process if we want to get anything changed. But overall, we're still working to the same timeframes. We expect some building work or some initial, what they call enabling work, to start in the autumn of this year, and that will be around the reprovision of the car park and some of the archaeological surveys, and then us to start building this lightly in 2025, with our opening date still 2027, 2028, but a lot of work still to be done, clearly, and that programme is always under review. So outside of the building design, we've included some of the other work that we're doing here, which many of you will be involved in, and how we start to think about the operation of this building is always a key focus. So in particular, we've been thinking about outpatient patient flow, how we get our patients from probably the ground floor of this building up into the outpatient area, and what we need to think about in terms of any digital systems and any workforce changes to make that a reality. Lots of you have been starting to think through the day unit model in terms of that staffing, as we know that's a key question we need to answer. And Elaine's done a lot of work with the various stakeholders around an emergency response, the Ops Centre, the rapid response team, etc. So still lots to get our heads around, still quite a lot of work to do around the transition plan, and more around what we think the clinical pathways will be about this time, and how that works with our regional colleagues. And then really finally, so probably we need to start up some different working groups into the autumn. I know office space is everyone's favourite topic, and that's something that we will need to start to delve into a little bit more, because we really haven't made any decisions around that at the current time. And also keen to start a particular group looking at the breast unit, because we haven't had much focus on the breast unit. So lots of things for us to do in the coming months. So thank you everyone for your help and input so far. It's going to get more exciting as we move on to this next phase.
Thank you, Carrie. That's brilliant. If anybody has got any questions I didn't say at the start, please add them to the chat and we'll try and pick them up. It makes me think that we might start seeing people in hard hats wandering around in the not too distant future, which is very, very exciting. And I think something that we're trying to do across all of our services now is think about how will you work in this building. So if your service is moving in, or even if it's not moving in, how are you going to work when people are based in this building? Can we start to make some of those changes now to how we do things? or even if we just have to start a list of things that we need to change. So thinking about the previous conversation here around policies, dare I say we're going to have to go through all those policies, and where we've said that something happens on C10, we will be referring to ward, whatever we're going to call it in the cancer hospital. And there's a huge amount of work to do just for changing, say, how we do things and where we'll be based and how we'll talk to each other and things like that. So it's going to take a lot of working through, but very, very exciting. So I look forward to people in hard hats. Lovely. Okay, let's move on then. So next, Gina, I'm hopeful, and I don't know if we've got Helen with us as well, or just Gina, to talk about our Cancer Patient Partnership Group.
Hello, I think it's just me and Hannah today, isn't it, Hannah?
Just you and Hannah is beautiful. Thank you very much. It's all yours.
Thank you. Kevin, are you controlling this? Thank you. So we're here to talk about the CPPG. But first of all, I'd just like to read out what co-production is, because that is essentially what the CPPG do. So co-production is a way of working that involves people who use health and care services, carers and communities in equal partnership, and which engages groups of people at the earliest stages of service design, development and evaluation. Co-production acknowledges that people with lived experience of a particular condition or healthcare pathway are often best placed to advise on what support and services will make a positive difference to their lives. You can go to the next page. So our co-production group is the Cancer Patient Partnership Group, which is a group of patients and carers that have used cancer services who work with the staff at Addenbrooke's to improve cancer services here. At the moment, we're meeting bi-monthly, alternating between online and in person. We always ensure that the patient, carer and family perspectives are heard. We also have representation from CPPG members at hospital committees and planning meetings, such as our chair attends the cancer board. We've got people on the outpatient experience group. And we also read leaflets and make sure that patient information is easy to understand. Participate in many different projects, big and small. And projects can come from the CPPG as well as staff bringing them to the group. Next slide. Back one. Thank you. So the CPPG has been running since 2012, so a really, really long time. And over that time, they've been involved in so many different projects. So they contributed to the redesign of the oncology outpatients department. They worked with NutriCheck on the neutropenic sepsis finger prick test, which was a fantastic project and had so much great feedback. They've been involved in MDT pathway improvements, the information packs or blue packs for new cancer patients. They're in the process of creating informative videos made by patients for patients. We also link in with the patient advisory group for the new cancer research hospital. And they're also involved in trust-wide projects such as the Call Me campaign, Please Write to Me, and the Hospital Gowns project. So going forward, we're actually out for recruitment at the moment. So if you've got any patients or carers that you think would be a great fit and would like to get involved in the CPPG, please let me know. And also, if you have any projects coming up, big or small, that you think, oh, the CPPG would be a great part of that, also get in touch and let us know. Anything else I need to add, Hannah?
No, thank you, Gina. I think you've summarised things really well. I just wanted to add, I suppose, that co-production isn't really something that's a nice to have anymore, particularly in our Cancer Directorate services and beyond. So we're working with cancer patients throughout the hospital, not just in the Directorate. So, you know, if you've got a project starting, service development, we want to get patients in there from the start. It's not something that you can just that we think should just be added on as a nice extra. It's really how we should design our services. And as you'll know, listening to our CCRH colleagues we're working closely with, absolutely patients are involved with everything we're doing to do with CCRH, as should be. So yeah, please get in touch, as Gina said, if you've got any projects. If any of you think of any patients who'd like to get on board with us, we'd really love to hear from you. And we're going around various meetings, aren't we, Gina, to raise the profile of CPPG. Thank you all.
Thank you.
Thanks, Gina. It's as you say, hugely important. I know I met with a patient and his wife to talk about the sarcoma pathway and how patients are referred in for diagnostics, and I had a bit of an idea about how we could change it. And talking to them was absolutely amazing. It really confirmed to me what our idea was actually going to work, but actually they added to it, and it meant that we got things even better when we first launched it, and they were part of the whole project with me, which was brilliant to work with people who had actually been through it and experienced it themselves. So yes, fantastic. So please, all of you, if you've got somebody that you think might benefit us, might want to come and get involved, they can be as involved as much or as little as they want, but if they want to volunteer, they do need to come and do something and be engaged. We don't want silent people, really. And yeah, please, if people just want to chat with Gina to find out a bit more, then please put people in touch. It's really, really important. Super, thank you very much. Where are we going next? We are going PIA, Teenage Young Adults Operational Delivery Network. All yours.
Thanks, Claire. Right, so TYA, I thought I'd start with a bit of an overview of what the cancer incidence rate is. Thankfully, it is relatively rare to have cancer as a teenager, young adult. Also, just to give you, to put it into context, we have TYA starts at, or TYA ODN starts at age 16 and goes up to patients' 25th birthday. So patients who fall into the category of over 16 but under 25 are TYA patients. So there's just over 2,000 new cases across the UK annually. So it is a rare cancer, thankfully, but in the east of England, we have a higher incidence of young people affected by cancer than in other parts of the UK. And along with that, we've also got the poorest outcomes in cancer in young people. There's probably very many reasons behind that, but they are the figures as pulled from CUH for the 2 years between 2016 and 2018. Do you want to move on to the next slide, Kevin? Okay. So when we talk about TYA cancer, we're talking about across lots of different cancer types, with the most common cancers being, well, other cancers and melanomas, but then lymphomas, germ cell tumours, and then other groups, most notably brain cancers and leukemias. So there is, teenage and young adults can get cancers from any of the cancer groups. They tend to be picked up later, which probably ties in with them having poorer outcomes than in other cancer groups. And there's probably a multiple reasons for that, which I'm not going to go into. So can you move on to the next slide, please? So the TYA cancer timeline, how we've got to the operational delivery networks of the ODN where we are now. So historically, it was a case of if you were under 16, you were treated along paediatric pathways. If you were over 16, you were treated as adult pathways. On adult pathways. This changed in 1990 with the formation of the Teenage Cancer Trust. And then the Teenage Cancer Trust has really been pushing forward and making headway in terms of creating TCT, Teenage Cancer Trust units, with the first one opened in 1990. And then we kind of skip on along to our own at CUH TCT unit being built and opened in 2012. And the current picture is, as you can see there are 28 teenage cancer trust units across all 4 nations of the UK. And then in 2021, there was the introduction of the Children's and TYA Cancer Operational Delivery Networks. In fact, it's probably a bit earlier than 2021, but I came into post in 2021 at the start of the Children's and TYA ODN being introduced in England. So this is England rather than across the UK. And what we've been doing is we've been working with, first of all, draft service specifications. So there's new service specifications. First of all, they were in draft, and then the children's specifications were published in, I think, 2022. And we've literally just had in 2023, I think in May, new service specifications for TYA cancer. And TYA cancer is, so CUH is the principal treatment centre in TYA cancer, with a number of designated hospitals allocated across the region. So we work regionally across the east of England. We have a slightly different geography from children's, which is not confusing at all, honest. But we have to work as well with the hospitals that are, or with the operational delivery networks that intersect with our boundaries. So most notably with North Thames, but also with Thames Valley and Wessex, who work in the west of the region. Really good at geography, so yeah, they work in the west of the region, and also North Thames, because some of the patients that may have a choice between going to Cambridge for their treatment or into London for their treatment, depending on where they live and where their cutoff is across the region. So little map there with a rough kind of roughly drawn what the area includes. Next slide, please, Kevin. But this is it laid out in a different way. So we work with a number of different ICSs and a number of different hospitals. So a hospital doesn't have to be a designated hospital to fall within the region. And I've tried to lay this out here, and also demonstrate where we are with children's and how the geography differs from the Children's Cancer Network region. So you can see most of the hospitals that most of the hospitals are shared between Children's and TYA, but some of them are fall into North Thames, but fall into Children's at CUH. So it is quite a challenging sometimes to think what's in region and what's out of region. So that's kind of a little bit about the background, and then onto, thank you, our aims and strategic priorities. So these are taken from the service specifications and include, I mean, I've tried to sum it up to improve the experience of care for children and young people who are affected by cancer, but then that's broken down into some very specific aims around delivering age-appropriate care in age-appropriate settings. And obviously the TYA team has been working very closely with Carrie's team to make sure that that's taken forward into CCRH. It's very important to have integrated and joint care across the network. So when we're talking about some treatment being delivered within our principal treatment centre, our PTC, which is CUH, and some care being delivered across the region in our designated hospitals, to make sure that that's joined up and also equitable, so that patients, no matter where they are in the region, have the same opportunities to receive the same level and standard of care. It's also very important to increase participation in clinical trials across this patient group, because that's actually where we will see future outcomes being improved. So it's very important to create more trials for TYA patients to be able to participate in, but also to make sure that they have the opportunity when trials are open across all tumour sites, that the age range is taken into account to make sure that any patients from 16 and up can appropriately be recruited. Alongside that, tumour banking, because tumour banking is how we find out what tumours look like in young people, and again develop treatments to improve outcomes. Obviously the ODN is set up across children's and TYA, and the transition arrangements that patients have from children's to TYA could be improved. So that's another thing that we are looking at actively, to make sure that when patients move across from paediatrics into the adult setting and into the TYA setting, that's as positive an experience as possible. And then obviously from TYA services into adult services more formally when they leave the care of the TYA team. There's work to be done there, which we haven't started addressing yet, but that's something that is a priority to look at. Really interested in the work that Gina's doing as part of the CPPG, because it's really important as well that we have patient voices and patients involved in all of the work that we're doing, to make sure that we're keeping in mind from a patient perspective what's important to patients, and some of that is about making sure that patients are seen and treated in a culturally appropriate and sensitive way, regardless of their age group, and regardless of their background that they come from. I've been speaking at length to Julie about data constantly, seems, because it's also really important to us that we can back up what we're saying when we look at making improvements, to demonstrate that by robust data, to demonstrate that we are making the improvements and we are moving in the way that we want to. So genomic medicine is a really key theme throughout both children's and TYA cancer, and the service specifications, and embedding genomic medicine within TYA cancer services, so that every young patient, every young patient under the age of 25, basically from 0 to 25, has the opportunity to have whole genome sequencing. Move on to the next slide. So they're kind of a background of kind of what are strategic priorities, all ODN strategic priorities. And then for us in this part of the region, or this part of of England, our priorities are, we've developed some working groups that have some specific priorities for us to work on. So we've got a symptom management and palliative care group to make sure that every TYA patient has access to specialist cancer palliative care advice and treatment, because currently it's very patchy, and it's a bit of a postcode lottery. Depending on which part of the region you live in will depend what you have access to. So that's a really key priority for us. As I've touched on genomic medicine, so I won't go further into that. Psychological support, again, to make sure that we are meeting the holistic needs of all young people in this region. Again, trials I've already touched on, and fertility is another key area for us in this this region, to make sure that all young people have appropriate access to specialist advice and treatment where appropriate. And we've set up a working group around transition and late effects, and realised that probably they're two very big topics, and we've put them into one group together. Not the best idea that we've ever had, but so we've got two areas of focus for here, to make sure that all patients have smooth transition from children's into adults, and then adults, children into TYA, and then TYA into adults. And then also to make sure that every CTYA patient has a clear long-term follow-up package in place to support them once they leave the kind of the treatment part of their journey. We're also looking at how we make sure that our pathways for our patients between the ages of 16 to 24, how they come into the hospital or come into regional hospitals from primary care, but then also how they come into CUH as the principal treatment centre from the regional hospitals. So there are key priorities for us. And then if you move on to the next slide, the progress we've made so far is we've been reviewing last year's previous patient outcomes in terms of end-of-life treatment for patients and trying to understand where the gaps were for our previous patients, and trying to look forward as to how we can close those gaps for patients from now on going forward. It's a slow process, as most things are. Genomic medicine, we've actually created a new post that spans children's and TYA, but largely sitting within TYA. And this is a genomic medicine CNS post. And this is, again, to understand kind of what happens currently with our CUH patients around genomic medicine, whole genome sequencing. Are patients being offered it? If not, why not? What are the barriers? How can we remove some of those barriers? And then to be looking region-wide, what do we need to have in place to make sure that all patients, no matter where they opt to have their treatment across the region, have access and are offered whole genome sequencing. Within our trials working group, the progress is really around trying to understand what the barriers to recruitment and retention in trials is, and also looking at what trials are open elsewhere in the region to make sure that if the trial isn't open here, that would be appropriate for a young person to enter, that there is a process and a pathway in place to refer them elsewhere to be able to access trials. Within our psychological support, we've been doing a lot of scoping to try and understand what the referral numbers are and what the existing provision is across the region, and again where the gaps are. So an awful lot of scoping being done. Within fertility, we've got a fertility study day that we're planning for the end of September, which is really exciting. And this is to go out to the region, but obviously anybody from CUH is very welcome to attend. Anybody working with younger patients to come and hear what the challenges are for offering fertility options to patients, and what the pathways that are being developed are looking like. So transition and late effects, again, set this up as one group, but we've got two big work streams underway, which is around reviewing what currently exists across the network for the transition pathway, and what the barriers for having a good transition process are, and trying to address those, and thinking very much region-wide. And then also looking at what our long-term follow-up information is, and what guidelines are in place, and what there needs to be in place, what's missing from that, to make sure that patients feel supported, and are clear about access back into the service if and when appropriate. The biggest challenge that I've got at the moment is trying to understand what the referral pathways are for 16 to 18-year-olds across the region, and we've done a little bit of scoping around this, but there's more that is needed, because I think if you're working in oncology, the pathways probably when you get to oncology are relatively clear, but we need to understand what happens before you get into oncology, what those pathways look like, and how we can improve them, so that we don't have anecdotal evidence of patients taking a long time to be bounced around the services until they actually come into oncology, and hopefully that will have the biggest impact on overall outcomes, because obviously we all know that getting patients diagnosed earlier generally means improved outcomes in the longer term. And then just a last slide to leave you all with why TYA is different, because teenagers and young adults just think differently. They have different priorities and different challenges, and I think a lot of teenagers think they're indestructible until they discover that they're not. So just leave you with that, and if you've got any questions, fire away.
Thank you, Paya. That's a whistle-top tour for what's been a huge amount of work for yourself and the TYA team. I think, yeah, most of us can't imagine having cancer as adults, let alone having it at probably most crucial time in your life as a teenager. So a huge amount to think about around the patient, not just about the cancer, which I think is really important. Lovely, thank you very much. We are going to move on next to Michaela, please.
Hello, so my presentation today is on transgender care within CUH. Next slide, please. So we're currently moving to version 2 of the transgender care policy we have within Addenbrooke's. And sometimes I've been asked a random question about this. We're actually working on the development list with Claire Hawkins, who's head of patient experience and engagement. Why do we have a transgender care policy? Well, the reason is to support our transgender, non-binary and gender questioning adults and young people who access our inpatient, outpatient and surgical services within Addenbrooke's. So in very simple terms, the policy covers the law, particularly with regard to the Equality Act of 2010, whereas particularly as a public organisation, we have a duty to promote equality of opportunity and foster good relations with our patients, and ensure that we can eliminate unlawful discrimination between people who are part of the protected characteristics with regard to gender reassignment. It also covers detailed information on how we provide care for our trans patients, including their families and carers, and also support and information for our gender questioning young people who access our trust services. Next slide, please. So within the policy, there are some definitions which are very useful. The reason why we have these definitions is so that we can best understand the gender definitions in terms of approaching patient care, so that we have the appropriate knowledge to be sensitive and understand how we can best treat them. So the first one we have on there is transgender/trans. So this is an equivalent inclusive umbrella term for anyone who feels that their gender identity or gender expression does not fully correspond with the sex that they were assigned with at birth. Cisgender or cis, this refers to a person who is either fully or partially identifies with the sex they were assigned with at birth. Non-binary or genderqueer, this refers to a person who identifies outside of the gender binary of male and female and may include bigender or pangender or third gender. So by bigender, we mean denoting or relating to a person whose gender identity encompasses two genders, and for pangender, this denotes or relates to a non-binary person who encompasses identities, multiple gender identities, and these can be expressed simultaneously or can fluctuate. Gender fluid, this denotes or relates to a person who does not identify as having a single unchanging gender. Pronouns, why do we use them? Well, it's important part of someone's identity, and generally the whole argument is basically boils down to respect. It's how someone would like to be addressed. It's ensuring that we use the language that a patient is comfortable with, and this leads to far more positive outcomes once we create and learn that understanding. Gender dysphoria. This refers to a person's sense of distress or discomfort around aspects of their gender experience. This can be physical dysphoria. So if a trans person is distressed about their genitalia or maybe their body hair, or it can be a social dysphoria. For example, if a trans person is distressed about people assuming their gender identity incorrectly and using incorrectly gendered language to refer to them. Gender realignment, well, this refers to the language used in the Equality Act of 2010 to refer to any part of the process of transitioning to live in a different gender. And the last one on the slide is Gender Recognition Certificate. So this certificate enables trans people to be legally recognised in their self-identified gender and to be issued with a new birth certificate. Not all trans people will or want to have a GRC, and if they do, they must be over 18 to have one. So an employer or service provider does not need to see a GRC to recognise an employee's or person's gender. Next slide, please. So on the second slide, I alluded very, very briefly to the legal framework that supports this policy. And there are, I'll delve deep a little further into the first of that, which is the Equality Act of 2010. So the Act itself protects people on the basis of gender reassignment from direct and both indirect discrimination and harassment. This includes discrimination by association and discrimination of people perceived to have the protected characteristic of gender assignment. And as I said before, we as a public organisation, a hospital as an example, we do have a responsibility to promote equality of opportunity and foster good relations with our patients. The next act referred to is the Gender Recognition Act of 2004. So this act provides trans people with the opportunity to obtain a legal recognition in their acquired gender by being issued with the gender recognition certificate that I alluded to earlier. Anyone with this GRC will be able to be legally recognised for all purposes as their acquired gender. And when someone has a GRC, any disclosure without consent of information about that person's gender history, which has been obtained in an official capacity, is an offence. There's a particular note regarding non-binary identities in the law, in that there is a lack of identity regarding non-binary identities within this current legal framework, and they're not currently recognised within the law. The descriptive term used in legislation is gender reassignment, which is a very narrow definition of what it means to be trans. But best practice within this Act and under the Equality Act 2010 reinforces the necessity to treat all individuals, including non-binary people, as you would other people with protected characteristics. Next slide, please. Further within the policy are general care principles, and I'll go through some of the headings and elaborate more on them. So, for example, it delves deeper into appropriate identifiers. So appropriate identifiers are items that staff should consider using, such as initials and surnames on bedboards rather than first names for all patients, be they trans or cis. However, also staff must always ask what the patients prefer to be addressed by. And equally, extra care may be required to ensure the dignity and privacy of trans patients, particularly post-operatively or if unconscious for any reason. For example, take extra care if a trans person is required to remove their clothing or wear an open gown for a procedure because they may feel especially vulnerable. If a trans person in your care is wearing a wig, please be careful not to remove it unless absolutely necessary for the procedure and the trans person is unable to do it themselves. Using toilets and showers. Trans people have equal rights to use and access single-sex toilets or showers, and they should use the facilities which they are consistent with regard to their gender identity. Where available, gender-neutral toilets and facilities should be offered. There are further general principles alluded to in the policy, in that we treat trans people with the dignity and respect that we treat any of our patients, and that we show respect and courtesy and avoid negative facial expressions, and by speaking to trans people as you would any other patient or service user. that we try not to make assumptions about people's gender identity by making assumptions about their appearance, that we don't make an assumption about their medical issues based on their gender identity. For example, a person being suicidal is not necessarily because they're trans or they happen to be on the autistic spectrum. Where possible, we avoid using gendered language. For example, if we're having a conversation about someone's menstrual health, that we don't use the term women, we just use the term people. So the presence of a trans person in your ward or department is not a training opportunity. What it is a chance for us to get care right and ask sensitive questions to get to that stage. There is also detailed information on how we help inpatient and outpatients, both for adults and young people in Addenbrooke's, and so that we use the appropriate language to help them feel comfortable and also ensure that they are admitted to the appropriate areas. For example, particularly for non-binary people, asking where they would feel most comfortable. And this is a subject that can be discussed and then explored and then dealt with. The latest iteration will be published on Merlin. We're just going through the final stages at the moment before it can be ratified. We're particularly working on some aspects of patient safety, but also information on EPIC recording that can be shared with groups, which is another item I'll come to as well. We actually do have some additional fields on EPIC regarding demographic information, where we can record the legal sex, the sex assigned at birth, and also someone's sexual orientation. There is also a gender identity field that has limited access, only I believe for senior managers in the e-hospital team and operational matrons. These are the people currently that can complete that field, but we're hoping to improve access to that further on. And the last slide, please. So here is just a few examples of the training that we have available on our DOT system that people can take part in. So there is a trans and non-binary awareness session, a supporting trans and non-binary people at work guidance session for managers, and also an LGBT awareness session, all of which are very, very useful to understand the terminology. I know it's a lot to take in, but we do have a duty to understand and help these patients who are already going through a tremendous amount, both mentally and physically, and the policy is being improved to ensure that that language is appropriate and also interpreted kindly and sensitively. And we hope to have this in version updated, I believe, in the next 3 to 4 weeks. And in addition to that, there will be a discussion on a forthcoming 8/27 meeting where myself and I believe Claire Hawkins hopefully will be discussing the key points of it once we've finalised it. So that's the end of my presentation. Does anyone have any questions?
Thank you, Michaela. That's fantastic. Some really, really important things there for people to think about. Kirsty's waving. If you've got a question, Kirsty, do you want to stick it in the chat? Is probably easier, unless it's
Okay, will
that
do.
can't go in the chat. Thank you. But yeah, really, really important. And I guess, Michaela, obviously those training courses there are available on DOT, but if people can't find them on DOT, we might try and put a link on, maybe when this presentation is shared, it might be that we can find them through that way, because I know DOT can be a little bit of a minefield sometimes to find things.
Yeah.
But yeah, please encourage your teams. I was going to say particularly if you're patient facing, but actually anybody, this is about staff and patients as well, isn't it? So please encourage your teams to do that training. Thank you very much, really helpful. So I think that's bringing us towards the end now, just some directorate bits and pieces to go through. And I think it's all wonderful, good, brilliant news, I think. So the next slide, Kevin, please. So this is my regular plug. So this is our innovation change station. So sounds really complicated, sounds really scary, and I promise you it's not Dragon's Den. This is an opportunity for any of you, absolutely anybody, any job role, any band, anybody, to raise any ideas or things that you think drive you mad and you'd like to fix. This is the route where we can get you then either some funding, some help, whatever it might be. We've had some fantastic things come through this route. You know, staff rest areas. We've had patient signage for things, we all sorts of things. Nothing is a bad idea at all. So please use this opportunity. Just because you've submitted something doesn't mean you then have to fix the problem. So we can absolutely provide some help and resource to get things done. ACT are really keen on this. So again, anything that needs funding, we can often get some money to do things. This is for everybody to use. So please use. There are some Connect pages, which is what links you there. But if you search on Connect for Cancer Innovation Change Station, you can find it. So that's my plea to give you guys a bit of homework to do. And the next slide is one that always makes me very proud and a little emotional. So a huge congratulations to everybody who was nominated for the CUH Awards. We have got some fantastic nominations, and when you read what people have been nominated for, it is brilliant, and there's some wonderful pictures there. We couldn't quite fit everybody on the slide, but there's some fantastic pictures of you all collecting your nominations. If you watched the 827 last week, you will see that the nominations now have moved through to the next phase, the final sort of short list of people who will go to the grand event, which I think is September, October time. And very, very proud that our cancer assessment unit and the bone marrow transplant nurses have been finalised for an award alongside our public choice nominees, Dr. Besser and Kate Nolan, who have been nominated by patients, which is fantastic for a directorate to have 4 nominees in the finals is absolutely brilliant. So a massive thank you to you all, and congratulations to those people in those teams. I know particularly for the cancer assessment unit and the BMT nurses, there's a huge amount of hard work and a lot of pain probably that went into that award nomination. So thank you. It's been a really tough year for you guys. Wonderful. And thank you very much for the people clapping. That's all very sophisticated of us today. Lovely. So that was all I wanted to say, really. A massive thank you to everybody. If you've got any questions, please put anything in the chat that you want to do. I've seen Michaela's been answering away. Thank you very much. But anybody's got any other questions? There was one thing that I just wanted to do a reminder of, and sorry, it's a bit of a grumpy reminder. Please just be aware if you have got any patient identifiable information about patient lists, MDT outcomes, clinic lists, whatever it might be, that we are disposing of those in one of the shredder bins and not leaving them on chairs, corridors. We've had an incident come through where one has been found by a member of the public. So please make sure you are disposing of those properly and remind your teams. And a massive thank you from us as a senior team. It's enjoy your summer holidays, and hopefully you are all getting a break at some point or other. And we shall catch you again for our next briefing in a couple of months' time. Thank you all.